Okay, welcome everyone to the second webinar in the JCMH Summer Webinar Series. We are really grateful to HHSC. They've always been a wonderful partner to JCMH. And for this summer webinar series, they are really leading the ship here on the inpatient commitment and treatment. And so I would like to thank all of them and start off with Dr. Jenny Simpson, who is the Associate Commissioner and State Forensic Director. I will turn it over to you, Jenny. Thank you very much.
Great. Thank you so much, Christy. Good afternoon, everyone. And I do want to again thank Christy and the JCMH for inviting HHSC to present on this important topic. At HHSC, we're committed to providing the best inpatient treatment for people acquitted NGRI while ensuring also that the safety of communities is prioritized throughout the treatment and discharge process. And so we hope that through this presentation, you're going to have a better understanding of what happens after a person has been ordered to receive inpatient treatment. And then if ordered by the court, what happens in the transition from an inpatient to outpatient commitment. You'll see throughout how our state hospitals provide treatment tailored to the goals of an NGRI commitment while also assessing for risk and appropriateness for community reintegration. We have four great speakers from HHSC for you today. And if we can go to the next slide, I'll do some introductions for them. So first, we're going to have Dr. Andrea Wright, the Chief of Forensic Medicine for the Office of Forensic Services and Coordination, who will provide you with an overview of NGRI commitments and share some data and trends that we have from data HHSC collects. She's also going to walk through the statutory process after an individual is acquitted NGRI. Then Dr. Wright and Omar Hernandez, who's a forensic service coordinator for the Office of Forensic Services and Coordination, will discuss treatment for people acquitted as NGRI in the state hospital system. After that, we'll have Dr. Carla Galusha, the Chief of Forensic Psychology for the Office of Forensic Services and Coordination. She will share information on the planning process for discharge of people acquitted NGRI. Ashley Walton, who's the Director of Forensic and Jail Diversion Services Unit in Behavioral Health Services at HHSC, will then discuss the transition from an inpatient commitment to an outpatient commitment order. And finally, we're going to save time for questions and answers. So please be sure to drop those in the chat if you have them. And so now I'm going to hand it over to our Chief of Forensic Medicine, Dr. Wright, to get us started.
Dr. Wright, I think you're on mute.
Turns out they're not the ones with technical difficulties. I am. Sorry about that, guys. So, if we could go to the next slide, please. Okay, so we're going to start with the NGRI overview and the inpatient trends. So, next slide. Great. So, we wanted to give a quick review for those of you who may need a refresh or who were unable to attend the first webinar. Insanity is a legal term referring to a specific standard for criminal responsibility. In Texas, Penal Code 8.01 defines insanity, and the Code of Criminal Procedure, CCP, Chapter 46C, governs the procedures related to the insanity defense. The legal definition of insanity is this. At the time of the conduct charged, the actor, as a result of severe mental disease or defect, did not know that his conduct was wrong. But what does this really mean clinically? Statute does not explicitly define mental disease or defect, although it does say that the abnormality cannot show up only as repeated criminal or antisocial conduct. Additionally, statute does not explicitly define wrong, but case law has defined it as legally wrong. So in clinical terms, we operationalize this standard as due to the symptoms of a severe mental condition, a person did not know their actions were illegal or legally wrong. A finding of NGRI is an acquittal. However, as we'll see, there are usually some strings attached. When we go to the next slide, you can see that because the conduct was a result of their severe mental condition, psychiatric evaluation and treatment may be court-ordered if the person is determined to have a mental illness or intellectual disability. If there is a finding of dangerous conduct, then the individual remains under the criminal court's jurisdiction, despite the NGRI acquittal. For the purpose of this presentation, we will be focusing on individuals who fall under the dangerous conduct category. We will also define dangerous conduct a little later in the presentation. Next slide. Okay, so this slide gives a visual of the next steps once an individual is acquitted NGRI with dangerous conduct. Each of these steps honestly could be their own webinar, but we'll just use this as a primer for the next sections. So in brief, once the court determines the individual is NGRI and there was a dangerous conduct finding, they get committed to the state hospital for evaluation and treatment. As the treatment progresses, an outpatient management plan, or an OMP, is created with input from the determined community treatment and supervision providers. This OMP is then presented to the court. If the court approves the plan, the individual is discharged from the state hospital and transitioned to an outpatient commitment. Treatment and supervision continue in the community setting under the criminal court's jurisdiction until it is determined that the individual no longer requires court-ordered intervention for safety, or until the maximum time of the would-be sentence is reached. Next slide. So now that you've had the primer, we wanted to give you some data on the trends seen within the hospital system. There's been a lot of interest lately regarding individuals acquitted NGRI, and I think that this slide highlights some core elements of an NGRI commitment. Overall, the number of individuals acquitted NGRI and admitted to the state hospital is low, and it's been relatively consistent, unlike some other commitments to the state hospital system. The second row shows that this population only accounts for between 2.6 to 3.1% of the total hospital admissions each fiscal year. If you look at the next two lines, you can see that the number of NGRI acquittees who are discharged from the hospital each fiscal year is even lower than the admissions. Fewer discharges than admissions means more time in the hospital, and the next row shows that. I happen to find it pretty interesting that the length of stay has increased since fiscal year 22, despite the relatively consistent admissions and discharges. We'll talk about this a little bit more. And the last line shows that the average daily census, which now indicates that about 1 in 5 of the individuals served within the state hospital system are on an NGRI commitment. Next slide. Okay, so this graph is really just another way of looking at the trends that we just discussed. The navy blue line at the top of the graph shows the total number of individuals on an NGRI commitment who are served in the state hospital within the fiscal year. The red line shows the number of individuals admitted under the NGRI commitment that fiscal year, and the green line shows the number of individuals on an NGRI commitment who were discharged that fiscal year. So you can see that the total number of individuals on an NGRI commitment exceeded the number of admissions and discharges, though has stayed relatively consistent. Next slide. Okay. So, as we mentioned in the initial data slide, the length of stay for individuals on an NGRI commitment has increased. Numbers are not exactly my strong suit, so for those of you in the audience who may relate, I converted a few of the length of stay by days into years. So fiscal year 23 had a length of stay of 2.89 years. Fiscal year 2024 is 2.92 years. Fiscal year 2025 is 3.85 years. And fiscal year 2026 is 3.5 years. So we are looking at just under 3 years to almost 4 years in the hospital. These numbers may be surprising, particularly if you're familiar with other types of hospitalizations. While there are a multitude of factors which impact the length of stay, one of the main factors is the shift in treatment and goals for this type of hospitalization. These goals will be discussed more later on, but I wanted to give you a little bit of understanding for this longer length of stay. I also want to make it very clear that I'm not saying individuals acquitted NGRI are staying too long in the hospital. Instead, I'm saying that the nature of this hospitalization is different from the others, and the process of treatment, programming, and community transition takes longer. Next slide. Okay, so this is a heat map. I just learned that term, didn't know that. This is a heat map for the counties with individuals who, the counties who have had individuals acquitted NGRI and committed to the state hospital system. You can see from the map that although the majority come from urban areas, we have individuals acquitted NGRI and admitted into our hospital system from all over the state. Okay, let's go to the next slide, which basically says we are going to switch gears and get into the NGRI verdict. Okay, remember when I said that we would be discussing dangerous conduct later? Well, we've arrived. So once an individual is found NGRI, the court must determine if the offense involved dangerous conduct. CCP Chapter 46C does define the criteria for dangerous conduct, and it's spelled out as this. Ultimately, the court must determine if the offense involved conduct that caused serious bodily injury to another, placed another person in imminent danger of serious bodily injury, or consisted of a threat of serious bodily injury to another through the use of a deadly weapon. Next slide. Remember when I said we'd focus on acquittees who had a finding of dangerous conduct? This is the reason why. Only acquittees who were determined to have dangerous conduct stay within the criminal court's jurisdiction and are ordered into the state hospital system. The rest of the presentation is going to focus on the 30-day evaluation commitment and the different possible dispositions. Next slide, please. Before we can discuss the initial commitment itself, we need to discuss the different placement options within the state hospital system. The determination of dangerous conduct does not automatically mean that the acquitted person requires a maximum security environment, though there can often be overlap. An MSU setting is the most restrictive treatment environment in the state hospital system, and certain charges are statutorily determined to have an automatic MSU placement. However, HHS does have the ability to review the case and waive the need for an MSU placement if it is not deemed clinically necessary. A full discussion of MSU procedures is out of the scope for this presentation, but overall, the MSU setting is appropriate for those deemed manifestly dangerous, which is a clinical criteria and different from an NGRI finding. As this slide indicates, the MSU treatment is generally focused on treating immediate risk factors for violence, while a non-MSU setting shifts to treating more long-term or complex risk factors. So let's go to the next slide, and now we can focus on the initial commitment. This commitment serves two purposes: to evaluate and treat the individual, and to provide the court with information to help inform decisions regarding placement at the disposition hearing. It's a brief commitment, only 30 days. This time period is dictated by statute and the fact that the disposition hearing must be held not later than the 30th day after the date of acquittal. Statute notes that the hospital recovery team is to evaluate the individual's current psychiatric functioning. We are also to evaluate what treatment, if any, is necessary to maintain safety and in what setting the treatment can be provided. This information is given to the court in the form of a report, which is due to the court as soon as practical, but not later than the 4th day before the hearing. Okay, next slide. So these are the specific elements statutorily required to be included within the 30-day report. Essentially, the report must indicate if the person meets criteria for a mental illness or intellectual disability, and whether it is a severe illness or disability. We are then to discuss safety to others and civil commitment criteria, as well as recommended treatment and supervision options. As noted in the last slide, we need to indicate which setting the treatment and supervision can be provided. Ultimately, can it be provided in the community, or due to safety reasons, does treatment still need to be held in the hospital setting? Let's go to the next slide. So when we are commenting on and making recommendations regarding the treatment setting, Chapter 46C lays out these specific criteria to be considered. The primary determining factor is safety to others. This is different from a typical civil commitment criteria in which the standard is a danger to self or others and includes a gravely disabled prong. When we go to the next slide, you can see that we're going to talk a little bit more about determining the setting, the treatment setting. Many of the acquitted individuals have received treatment in jail, or they quickly respond to treatment in the hospital. This psychiatric stabilization could indicate that there is no longer an imminent threat of danger. However, that acute stabilization does not mean that they are automatically appropriate for a transition to the community. In these cases, the recovery team must assess the acquitted individual's risk should they fail to continue treatment. Such specific factors considered are the individual's insight into the need for medications, the ability to manage possible medication side effects, and the availability of community treatment options. The outpatient setting is only considered appropriate when the individual is no longer likely to cause serious harm to another, and they are likely to comply with a court-ordered treatment regimen. Next slide. Okay, so now we're going to shift to the state hospital treatment. And if we go to the next slide, we can talk about it. So we've reviewed the data trends. We've talked about the initial 30-day evaluation and the report to the court. We've also talked about the length of stay and that an NGRI hospitalization is different from other types of commitments in the state hospital system. Now, let's talk about the how and the why of this difference. In all psychiatric hospitalizations, we are working towards psychiatric stabilization. However, in civil commitments or in different forensic commitments, the focus is on current and immediate psychiatric functioning. In an NGRI commitment, the focus shifts from immediate to long-term recovery and safe community reintegration. Some of you may have actually already noticed this shift when we were discussing settings in the last slide. Ultimately, This means that we are evaluating and treating the individual's specific factors which may impact the risk for future violence, recidivism, and treatment adherence. So how do we actually do that in the hospital? Well, the next slide shows that psychotropic medications are a part of this treatment, but it's really just the first step. In fact, as we've already discussed, many of the acquitted individuals have already been psychiatrically stabilized by the time they're admitted to the state hospital. Once the immediate symptoms are stabilized or more adequately controlled, the focus shifts to maintaining this level of functioning. And you'll see some of these questions. You might think that they appear somewhat simple, but I can assure you it's not as easy as it appears. The individual has to have a baseline understanding, if not acceptance, of these questions. Why are the medications prescribed? This goes from big picture of treating the mental illness itself to the specifics of which symptoms they address. They need to know what medications are prescribed. Again, we go from general class of medication to specific name of the medication, the indication, the dosage, and the timing of the medicine. They also need to know how the medications impact them. This includes both positives, meaning the benefits of the medication, and the negatives. You most commonly think about side effects, but there's other things too. The issue of being on medications in general, maybe having to receive an injection when they are very scared of needles, and also remembering to take the medicine every single day. Another area of focus becomes teaching the individual both how and when to talk with their treatment providers. Again, this may sound simple, but that's inaccurate. I'm not going to ask for a show of hands, but I will say I'm curious how many in the audience feel comfortable telling their physician about all, and I do mean all, their issues and concerns versus just trying to sugarcoat some of the problems and then get out of the office as soon as possible. Yeah, I thought so. Probably a lot of people. And we have to help our individuals recognize that this is not a strategy for them. So if we go to the next slide, we're also looking at clinical formulation. So in addition to medications, we use clinical formulation to help create individualized treatment plans. These domains are not just conceptual. We are observing the individual in our hospital, how they interact with the team, how they interact with others. We are looking at their behaviors. We're looking at their ability to recognize their symptoms, to use coping strategies in real time, and to seek help appropriately. When I talk about NGRI and hospitalization and treatment, I often refer to it as breaking the surface, and these areas show how we do it. So the individual has to work to know what their mental illness or disability is. They have to know how it shows up for them. For some of our individuals, they have to work on actually accepting that there is a mental illness or disability. They also need to work on monitoring it for themselves and how they respond to treatment. They need to look at triggers. These are emotional, physical, and situational. Also, they need to know why those triggers exist and how to avoid them, and what to do when they can't be avoided. The treatment team and the individual needs to look at the pattern of thoughts and behaviors. Does the individual have some insight into why they may be thinking this way or what their beliefs are and the way they interact with others? Particularly how they interact with family members, friends, or peers, and how they respond under stress. The individual needs to have an understanding of their strengths and their limits. They need to be able to recognize these. They need to be able to build and reinforce healthy coping strategies. They also need to know what to do when they are approaching their limit. Can they recognize when this is happening? And then lastly, they need to be able to seek help, to look for assistance. Are they willing to engage in it? What's their capacity to access the supports in real time? So as you can see, it's quite in depth. If we'll go to the next slide, this is the last thing that I'm going to talk about before I hand it over to Omar to talk about hospital programming. But what I want to talk about is the fact that the recovery teams have to help the individual discuss the event itself and understand how it happened. You've heard the expression of peeling an onion. That's a pretty apt analogy for this type of hospitalization. The recovery team has to meet the individual where they are and help them confront the event. They need to be able to understand what led to it and why. And then they need to be able to deal with the consequences and the aftermath. These individuals' lives and those of the victims, if that's applicable, are forever impacted. Addressing this is a critical step in treatment, and understanding this can help prevent future episodes of violence. And with that, I will hand it over to Omar.
Thanks, Dr. Wright. So hello, everyone. So we know what needs to be done in treatment for individuals that have been found not NGRI. And so the question becomes, how do we go about doing that in the facilities? So on the screen, you can see an infographic that sort of breaks down how treatment is done at the state hospital. It all breaks down into 4 categories. You have clinical assessments, then therapeutic engagement, education and skill building, community readiness, and collaborative extensive discharge planning. I'm going to go over these in more detail in the next few slides, with the exception of discharge planning, which Dr. Galusha will do in the next section. Next slide, please. So first, we have clinical assessments and therapeutic engagement. So at the state hospitals, we use assessments and psychological testing to identify an individual's clinical needs, their strengths, and various risk factors. These assessments and the information we gain from them are done at certain points in an individual's hospitalization, but also whenever it's clinically indicated. And the information we gain from these assessments helps inform treatment decisions, as well as give us information on an individual's general treatment progress. That can also be helpful for us when we're trying to make decisions on certain programming, such as when we're looking at folks to participate in off-unit or off-campus programming. It can help inform if those decisions are appropriate. In the facilities, our individuals do engage in therapy. So we have individual and group therapy, but we also provide experiential therapy, such as art, music, recreational therapy, dance therapy. And our facilities do also do family therapy, or can engage in family sessions when it is clinically appropriate and feasible. And therapy is, in large part, where a lot of that work is done that Dr. Wright was talking about in terms of addressing and understanding the offense. A lot of that work is done in therapy. In addition to therapy, individuals will also engage in substance use treatment when it's indicated, and can also engage in peer support services. So for those who may not be aware, peer support specialists are individuals with lived experience and training that can provide encouragement and assistance to individuals with mental health issues. We found that their lived experience can be particularly helpful in facilitating engagement in treatment, especially when individuals may encounter barriers or become discouraged in the treatment process. Next slide, please. Next, we have education and skill building. In our facilities, individuals attend a variety of groups and classes throughout the week to learn about various topics related to their mental health, wellness, and recovery. On the screen, you can kind of see a list of the standardized topics and classes throughout our facilities. And I won't go through them all just for the sake of time, but I did want to point to the last bullet about the NGRI commitment. So individuals on a NGRI commitment go through programming that's specifically geared towards teaching them about their commitment. So they learn about the process that led to them being in the hospital, what it means to be not guilty by reason of insanity. We also talk about what they can expect for their hospitalization in terms of their treatments, but also potentially how long they may be in the hospital. And we also cover information to prepare them for the discharge. We talk about the discharge process, as well as inform them about some of the expectations that they may have to adhere to when they do get to return to the community. Next slide, please. So community readiness involves working with individuals to provide them with opportunities to practice and utilize the skills and knowledge that they will need to be successful in the community. In other words, how can we show the person may be ready to transition to the community? So within the hospital, some of the initial opportunities we provide for folks is there are opportunities to kind of take on more leadership roles. And so that could be kind of volunteering to help with like staff with unit activities or events. We also have worker programs where individuals can apply and obtain a part-time work position within the hospital. The positions can vary from the facilities, but in large part, all these positions can give the opportunity for individuals to earn income, but also just practice skills that will be helpful in the community, maintain a schedule, working with others, showing up on time, things that will be helpful once they go to the community and have to keep up with appointments and, check in with individuals in the community. And lastly, we also have off-unit programming. So some of our facilities sit on large campuses and thus offer the opportunity for other programming that may not be directly tied to the hospital, but is on hospital grounds. So a great example is at Austin State Hospital. They're on the campus. There's an Office for Communities for Recovery, a nonprofit agency that does 12-step and recovery meetings. And so individuals at ASH can obtain permission to go to those recovery groups as part of their treatment. Next slide, please. And so when it comes to community readiness, one of the big ways we could show that an individual is ready to potentially transition to the community is to have them participate in activities and therapeutic programming off hospital grounds, what we will often call off-campus passes. So one of the things to note about off-campus passes right off the bat is that these passes go through an extensive review process. Before they can be done, they have to be reviewed and approved by an internal hospital committee that then has to be reviewed by State Hospital Central Administration. And then it has to be approved by our Chief Program and Services Officer. And then it has to be approved by the committing court as well. So once all four things have been done, then folks can engage in these activities. The range of activities that folks can engage in on these passes is pretty wide, and our facilities are always looking at ways to, give folks more opportunities in the community. But some of the more common ones you can see there on the screen is we have volunteer opportunities where folks can volunteer in animal shelters or food pantries. There's also passes to practice life skills or obtain necessities that they'll need in the community. So, practicing going to a grocery store and making a list and buying the things that you need, going to the DMV or vital statistics office to help get an identification. There's also therapeutic programming where folks can potentially attend like recovery groups and 12-step meetings off hospital grounds. And then we also have therapeutic family outings where individuals can go on outings with family members. It can give an opportunity for the individual and family, especially if they will be involved in that person's care in the community, just kind of spend time together, see what maybe they will need as part of like that discharge planning support. And one last thing to know about these passes is that they are supervised, but individuals are always encouraged to take lead in these passes. So they're the ones that are engaged in the activity. They're the ones that are having to understand what they need to do and accomplish whatever the task may be. And staff are there to support, but it's very much the individual kind of like leading the way. And so with that, that kind of just covers programming in a nutshell. I can honestly probably talk about this for the whole session, but I'm going to pass it off to my colleague, Dr. Galusha, who will go over discharge and the discharge process with y'all.
Good afternoon. Next slide, please. So anyone who's ever worked in a inpatient setting or is familiar with it will know that discharge planning begins from the moment the individual arrives in one of our facilities. Dr. Wright did a great job of explaining the adjudication process and what it means to have been found not guilty by reason of insanity. And Omar just did a great job of outlining treatment and what that looks like in one of our facilities. This roadmap here gives some information about what it looks like once we start to get ready to move the individual towards discharge. So this is an overview of that, and we're going to talk about each of these particular steps in detail in just a moment. But basically, you begin by ordering a violence risk assessment once the individual appears close to ready for discharge into the community. Then the social worker, in coordination with the rest of the recovery team, begins working on an OMP and discharge planning. They complete those internal processes of looking for a placement and going through the steps involved in that. And then the hearing process begins and the physical discharge. So we're going to walk through those together. Next slide, please. So the first step is this violence risk assessment. The VRA or a VRA. So this typically includes one or more empirically supported risk assessment measures, and that's used by the evaluator in formulating their opinion regarding risk. And so it's important to understand this because it's not just purely based on clinical judgment, but instead it's looking at those factors which have been found to be most predictive of future risk and dangerousness, including those risk factors as well as protective factors and preventative management strategies. So the goal of the VRA is to identify those salient factors which may contribute to the individual's violence risk and then make recommendations that will allow for successful management of the individual to reside in a least restrictive environment possible. Next slide, please. So best practice dictates that we are always identifying the least restrictive environment for an individual where they can safely be maintained. The least restrictive environment is a setting that provides both the necessary care with maximum independence and minimum restrictions on freedom. So it focuses on that integration of allowing for specialized care, such as assertive community treatment or intensive case management, while also avoiding unnecessary institutionalization. One of the things that research has indicated is that in addition to the obvious costs of maintaining an individual in a more restrictive or harsher environment than is that overly restrictive environments can also increase physical and psychological risks, such as medical and mental health decline for an individual. It can increase trauma and re-traumatization for an individual that's held in a more restrictive than necessary environment. It can lead to institutionalization. And it can increase behavioral management issues. And I think sometimes that may seem counterintuitive if you're thinking, well, if we keep them in a very restrictive environment, we're going to have less behavior issues. It's actually the opposite. Another thing that's worth noting is that recidivism research actually indicates that harsher and more restrictive conditions do not deter future offending and may, in fact, actually increase the likelihood of future offending. And then another thing that's worth noting is that it may have a negative impact on staff and well-being, as well as institutional safety. So lots of reasons for why we are always looking for the least restrictive environment to safely maintain an individual. Next slide, please. So there's a few okay. There's a few times at which or points in the individual stay at which a VRA may be completed. Certainly the recovery team is going to refer that individual for a VRA once they believe that the person is appropriate or may be appropriate for community placement and outpatient treatment. But there's also times earlier in an individual stay when they may be referred, and that could be at points in time when there is decisions that need to be made about passes, privileges, or other treatment recommendations. So really any time that the treatment team believes it's appropriate to look at the risk of the individual, they can make a recommendation and have an evaluation completed. Next slide, please. So the VRA is a multi-step assessment that estimates the likelihood of future violence, and it includes recommendations for risk management. As I mentioned previously, we use a risk assessment tool. It's a specific instrument or a checklist that's designed to standardize the evaluation of risk, and it's only one component of a full risk assessment or VRA. This is important to note because the two are not synonymous. Sometimes you'll hear people say or use the term violence risk assessment when they're actually just referring to the use of a violence risk assessment tool. But a full violence risk assessment is actually a comprehensive psychological assessment. And using those two terms interchangeably when you're just referring to the use of a measure or tool versus the actual complete assessment can be confusing. So that's the reason for noting this distinction. Next slide, please. So the literature on risk assessment is actually very vast, but we know that the best practices for assessing risk includes consideration of the following components. First, risk assessment is context specific. We must first define the question being asked and frame the risk being assessed. So there are different types of risk assessments that can be conducted. For us, we're specifically looking at future violence risk. Clearly, we want to clearly outline over what time span we're considering and across what setting. So as previously mentioned, risk assessments can be used in our facility for a variety of reasons, but in these assessments, most often we're assessing risk for violent behavior in a community or outpatient setting over the next 6 to 12 months. So that distinction is also very important, is that we're predicting or we're attempting to predict or forecast risk over a fairly short period of time, 6 to 12 months, not for the next 10-20 years. So it may be the case that the person needs to be reassessed over time. Over the last 20 years, there has been rapidly expanding literature detailing the factors that correspond with particular types of violence among specific populations. So violence risk assessment must include an analysis of empirically supported risk and protective factors, which is done through the use of evidence-based tools or instruments to highlight relevant data, and it needs to be relevant to the individual who is being assessed. So while the majority of risk assessment VRA is rooted in research-derived data, best practice still supports the consideration of fine-grained or individualized assessment of risk, which includes consideration of factors that are unique to the person being assessed. So this can also include things such as specific threats of violence. It can include the neurocognitive status of the individual, and then of course their access to victims or weapons. Finally, research has highlighted the importance of clearly linking risk estimates to risk management plans, which provides the opportunity to design the least restrictive environment necessary to protect public safety, to consider specific contexts that may increase or decrease risk, and decrease risk and likelihood of violence. Next slide, please. Okay, so taking a closer look at the empirically supported risk factors, we can break them up into two types or two categories. You have static risk factors or risk factors that don't change or are unlikely to change. And then you have risk factors that are more amenable to change and or may change over time. So here are some examples of those risk factors. Many individuals we serve have quite a few of this static risk factors. And so, we may not really be able to do anything about those risk factors. Those are there and they're likely to stay with them. But we do have an opportunity to address those dynamic risk factors, those that are amenable to change. And so things like their insight into their mental illness or the understanding of the need for continued change, understanding of their own risk factors related to violence. We also can have an impact on their behavioral, affective, and cognitive stability and treatment and supervision response. Similarly, as Omar mentioned, dealing with things like violent thoughts or anger management, all of those can be focuses of treatment and address some of those dynamic risk factors. Next slide, please. So in looking at what goes into a comprehensive assessment of violence risk, this process begins with a review of relevant records. So that includes all of the information before the individual was admitted, including evaluations of their mental state at the time of the offense, which precipitated their acquittal. Available records from previous outpatient treatments, jail mental health records, and possibly records from other hospitalizations if we are able to access those, as well as records from their current hospitalization. The goal of this is to understand the individual's illness trajectory, patterns of violent behavior, and developing an understanding of historical risk factors that may have been present. The independent evaluator then meets with the individual and completes a clinical interview, which includes gathering additional background information as well as focusing on the individual's understanding of their mental illness, the factors that may increase their risk of violence or their risk for violence, excuse me. So those include things like medication non-adherence or substance use, and their understanding of their need for continued treatment outside of the hospital setting. A large focus of this portion of the evaluation is dedicated to understanding how treatment has helped the individual being assessed to take responsibility for their mental illness moving forward, including understanding how their mental illness impacts their behavior, the importance of psychotropic medications, adaptive ways to cope with any residual symptoms they might be experiencing, and their ability to communicate their needs with mental health providers. The evaluator often consults with individual treatment providers to gain understanding of how the individual has progressed through treatment at the facility, and may consult with involved family members or their support network in the community to further understand their perspective, particularly if the individual is wanting to discharge to live with family or be near loved ones. The evaluator may complete other psychological testing if it's determined that this information may help inform the overall conceptualization of violence risk. So that may include things like intellectual testing, neuropsychological functioning, or personality assessment. The evaluator then takes in all of the information gathered and applies it to the risk assessment tool, which most often is the HCR20 version 3, which research has collectively identified as the gold standard in violence risk assessment. So the HCR20 version 3 outlines 20 historical, clinical, and risk management factors that have been correlated with violent recidivism. And the evaluator will also consider the role of any mitigating or protective factors, including those specific to the individual's violence risk. And lastly, the individual will provide an overall risk assessment or estimate, and oftentimes it's communicated in categorical terms such as low, moderate, or high risk. and make associated risk management plan suggestions for mitigation of risk, either in an outpatient or inpatient setting. So it's important to point out that these risk estimates may include significant focus on dynamic risk factors and are time bound. And as I mentioned, 6 to 12 months period. Next slide, please. So I won't belabor this slide, but basically these are some typical kinds of inpatient risk management plan examples. In the first or below, you'll see some typical outpatient first outpatient, then inpatient examples. So you can see the outpatient examples largely focus on professional services and resources that will serve to mitigate violence, including recommendations for managing the individual's mental illness through medication adherence and meeting with case managers and individual therapists, placement in a structured supervised housing, etc. If it's the individual the evaluator's opinion that they are high risk and require further inpatient, then they may recommend some strategies to help facilitate moving them to a lower risk status. Next slide, please. In development of the outpatient management plan or OMP, the individual's recovery team social worker is the primary driver for the creation of the OMP. And the recovery team will utilize their knowledge of the individual along with that VRA that was provided by the evaluator to create the OMP. And the OMP will detail how care will be managed in the community to mitigate future violence risk as outlined by the VRA and promote recovery in the least restrictive setting while balancing those safety to the community considerations and legal requirements. The OMP is a standardized document. It's across facilities and it has two primary sections, presenting problems and services/recommendations. Next slide, please. So the OMP is created per our operating procedures, and as noted before, discharge planning begins on admission. It comprehensively addresses the individual's needs in the community, and it's coordinated among multiple stakeholders. So it's, as mentioned before, it's primarily driven by the social worker. Next slide, please. Some challenges that are commonly encountered is some placement barriers related to the severity of the offense or the specialized populations that require unique services, and then issues related to benefits. There's also often some LMHA service limitations. Sometimes the VRA will make recommendations for services or levels of care that the LMHA is not able to accommodate or willing to accommodate at the level being recommended. Lack of community resources can be an issue. Court reluctance to modify, again, probably not surprising, but there are times that the court is not willing or is reluctant to release the individual to community. And then we sometimes also have barriers that impact our ability to place the individual related to benefits. And there can be issues related to catchment area and either issues with services not being available in that area or an individual wanting to relocate to somewhere outside their catchment area, and courts often aren't open to individuals living outside their jurisdiction. Next slide, please. So the Forensic Consultation Committee is composed of 5 mental health. So once an individual is deemed appropriate for referral for a VRA, and the team has put together the OMP, they then are presented to the Forensic Consultation Committee. And the FCC is composed of 5 mental health professionals that review a recovery team's request and recommend that an individual be modified to an outpatient commitment. FCC sometimes do serve other purposes, but for the purposes of our discussion today, they're here to make decisions about whether or not a person is appropriate for that next step. It's important to note that the FCC is composed of individuals that are not part of the person's recovery team within the last 12 months, and they must not have had a personal professional involvement with the individual's hospital treatment in the 12 months preceding the meeting, and at least one member of the FCC must be a psychiatrist experienced in the care of adults. Next slide, please. So in making recommendations to the court, there's a number of things that are considered. First of all, key components include the treatment progress and compliance of the individual, clinical evaluations and reports, comprehend the violence risk assessment, and input from the team, input from the LMHA, LBHA, LIDA, or any outpatient provider or placement that's going to be included, and of course, considerations about the stability of the individual, any identified risks of future violence and how those have been mitigated, and the strength of the OMP. Public safety considerations with the least restrictive and most appropriate level of care is always the goal. Next slide, please. So our hospitals are continuously working to problem solve and address barriers when they present themselves. And once the OMP is completed, the team will request a meeting with the FCC to review the OMP and the team's recommendations for outpatient modification. Once the FCC approves, the superintendent will conduct a review to ensure all steps have been completed per the OP. And once the review is done, then the OMP, VRA, and physician certificate of medical examination and recommendation letters are sent to the court for review for outpatient modification. Per procedures, this should occur within 14 days of the request, but it does not always occur that way. Should the request be modified, then the court, the commitment order, should the request be approved, then the court will modify the commitment and the outpatient commitment order, and the hospital will work with the community stakeholders to discharge the individual to the community. Next slide, please. So the court must determine must make the determination, and they have to, based on the recommendations of the team, determine if there's a continued mental illness, if there's an ongoing risk to self or others, and a need for continued inpatient or supervised care. Possible outcomes of this is a renewal of the inpatient commitment, a modification of conditions, so perhaps a step down to outpatient commitment, or a release from the commitment. So that's a termination of the jurisdiction of the court. Next slide, please. So some thoughts about how courts can support successful determination and potential outcomes. First is during the hospitalization. One of the things that Omar mentioned is supervised passes, off-campus supervised passes, if requested and appropriate. We do make recommendations about that, and because we know that past behavior is the best predictor of future behavior, we're looking for opportunities for the individual to demonstrate that they can safely be maintained in increasingly less restrictive settings. So one of the best ways we can do that is by giving them increased privileges, increased opportunities to demonstrate safety on these supervised passes, so that when we make recommendations, we have as much data as possible on which to base that. So if there's concerns or by the court or by others, certainly collaboration and discussion is recommended and encouraged, and a great opportunity for there to be collaboration there between the court and the recovery team in the hospital. Prior to approving outpatient modification, we recommend that you confirm treatment and supervision outlined in the OMP can and will be provided to the individual as outlined in the code. And we want to ensure that all of the persons and parties responsible for administering the OMP and the supervision and the services are identified and have agreed to do that. A lot of times there's multiple parties that are involved in the care and supervision. And it's not always just the LMHA or the LIDA or the LBHA. Sometimes it's others, and it's important that everyone is identified as part of that process. Next slide, please. Okay. Once the individual has completed all of the responsibilities for the outlined in the OMP, and the court no longer has legal authority over them, or they've ended their court order treatment and supervision, there is an opportunity for termination of court jurisdiction. This can occur either when the maximum commitment period has expired, or the court determines that the continued oversight is no longer necessary for public safety reasons. Next slide, please. There are incidents or times when an individual will re-enter the system after an NGRI discharge. And some possible pathways back into the system is if there's a revocation of outpatient NGRI commitment, and that could be for a violation of the OMP, for a failed placement, or a clinical decompensation. This also sometimes occurs when there is a new charge and the individual has been found incompetent to stand trial, or a new charge and the person has again been found to be not guilty by reason of insanity and has been recommitted under a new NGRI commitment. Next slide, please. Finally, in looking at key drivers for system reentry, probably the most common key factor is clinical complexity. So serious mental illness, co-occurring disorders, and trauma. Often we see medication non-adherence or decompensation as a piece of that as well, or changes in community provider adjustments, changes in community provider, excuse me. So either their outpatient provider that they have selected is no longer available, or there's changes in their provider at the community level. Other issues can be substance use related, gaps in community supports, or housing instability, changes in risk over time, and limitations of legal oversight after discharge. One thing that I do want to point out, though, is that re-entry into the system is not always an indication of failure of the system or failure of the OMP. In fact, it can actually be perceived as the opposite in many cases. We know that individuals with serious mental illness do sometimes need that support, do sometimes need to re-enter inpatient settings for adjustments in medication or for supports at different points in their illness. So it can also be viewed as the process and the safety net working exactly as intended to support and identify needs when they arise and respond to them appropriately for these individuals. So I think it's worth pointing that out. Next slide, please. That's it, and I'll hand it over to Ashley.
Thank you, Dr. I apologize in advance that I am in the dark. It is storming in Central Texas, and my power went out shortly before this webinar, so please forgive the dark background, but thank you for having me. I'm going to be speaking a little bit more about the NGRI outpatient commitment, so we can go to the next slide, please. This is going to be a little bit broader than some of my colleagues at HSCS, since HHSC's role in monitoring and oversight for NGRI outpatient commitments is really a little bit more removed. But that being said, we have some insights and some things to think about in key practices. So if you're looking at CCP 46C, it outlines these specific conditions and criteria that must be met to order that outpatient treatment and supervision. And some of those have already been spoken to, but they're looking at whether or not the court has received and approved this comprehensive outpatient treatment plan. The court must find that the services described in that plan are available and provided, which Dr. Galusha just spoke to, and I'm going to elaborate a little bit on that. And also identifying those people, persons, entities who are going to administer that. And then they may order outpatient or community-based treatment and supervision to be provided by any appropriate county where the necessary resources are available. So something to note, and you will see that more people might be end up in a community where they're not originally living because those resources may not be available or as readily accessible to the extent that the person needs to be successful in the community where they're from. And so sometimes they will end up in a community very well designed and thought out, but that has more access to resources. And so it is important that when courts and treatment providers and the social workers in the hospital and the person who is discharging on an outpatient commitment or really thinking about everything that person needs to be successful in the community and that those resources are readily available and going to be provided. Next slide, please. All right, so statutory responsibilities of the NGRI outpatient treatment and supervision provider. So the court is the one who's ultimately going to distribute these responsibilities. Again, this is often, but not always, based out of that very comprehensive and well thought out outpatient management plan. That being said, the court does have a right to make changes. Should they like. But back to Dr. Galusha's point, if those changes are going to be made, or even if they are in accordance with that outpatient management plan, it's very critical for the person to be successful, for every party that is identified in the court order to be aware, to have agreed upon, so that we're not finding somebody in a community and the court is expecting something and the treatment or supervision provider was maybe less familiar with that specific nuance and maybe it's not available or the funding is not there. So this communication in advance is really critical to allow people to be successful and to have access to the resources and treatment that they need, as well as support. So in accordance with CCP Article 46C 265, there could be one identified person that could be like an LMHA, might be the identified provider of both treatment and supervision regimens, or it might be that there is a separate person. There might be an LMHA, or if not the LMHA, the VA or another entity who's determined most appropriate providing treatment regimen. Whereas in some counties or some situations, CSCD or adult probation might be identified and have agreed to be doing the supervision component. So that looks different across Texas, and it's going to look different for each individual person, as well as the county that they're ultimately going to be residing in, at least for this initial period of outpatient treatment. So those parties, though, are responsible for monitoring the condition of the acquitted person and determining compliance with the regimen of treatment and supervision. They shall notify the court and the attorney representing the state. It has to be it's a two-prong requirement. They must notify the court and the attorney representing the state if the person fails to comply with the regimen and becomes likely to cause serious harm to another. So there's nothing currently in statute that suggests that just because somebody is not complying with the regimen, the court must be notified. That being said, local jurisdictions, courts, the court order itself may have more stringent requirements in place. It can be that a court order is requiring the providers to notify them at other points in time. But by statute, this is what is required at a minimum. Next slide, please. Okay, so all kinds of different people might be involved in an outpatient commitment. Naturally, the acquitted person, the committing court. So again, I want to highlight that even if a person goes to another county, the committing court, which is where the person was originally adjudicated not guilty by reason of insanity, maintains that jurisdiction over this person and both that inpatient portion and then the outpatient modification if it occurs. The attorney representing the state, the defense attorney, that designated treatment provider, the designated supervision provider, if that's a separate entity, and then any other outpatient providers or services that are identified in that court-ordered treatment and supervision regimen. So as you might imagine, because everybody has unique treatment needs and things going on in the community and what's going to make them safe, and make them successful, these look very unique to that person. And so this can cause, if you don't have a nice structure in place, people can get lost or dropped off, or there might not be a process. It might be that in one county, the attorney has a very, the state attorney might have, they're wanting to file any sort of court paperwork, whereas in another, it might be the designated treatment provider. And that flexibility is allowable, but we just consider it to be best practice to make sure that anybody who is having somebody acquitted, not guilty by reason of insanity on an outpatient commitment works in advance, if possible, to have those process flows designated. And if you're finding gaps, to work together to decide what that's going to look like, so that nobody is assuming or thinking that somebody else is taking a piece of this, and unintentionally having an error in this process, or not committing, not staying to the requirements. Sorry about that. All right, next slide, please. Okay, so these are just some examples, and as you see in the nice bold red, this is a non-exhaustive list. So some examples of treatment providers are listed there on the left side of the slide, whereas supervision might be on the right. And you will see some overlap, right? As we discussed, it might be that the LMHA or LBHA is doing both. It might be that they're doing just treatment and somebody else is doing supervision. It might be that there is some kind of supervised living facility where the person's living, but that doesn't mean that that facility is responsible for the supervision, monitoring, and reporting. So again, it's fantastic and great that there's this variety of services, so that a person randomly can get individualized treatment. But it is just as critical then that everybody is involved, on the same page, knows what's happening before the person comes into an outpatient treatment setting, and then knows what's happening to continue to be monitoring and working with the courts to make sure that that court order is being adhered to. Next slide, please. Okay, so sort of harkening back those best practices, things that have been sort of identified and established and to be thinking about, particularly if you are a community who has not historically taken on a lot of not guilty by reason of insanity outpatient treatment orders, or even if you have, really wanting to be thinking about these local processes, because it is not HHSC's role and it's not by statute right now to be identifying exactly what's going to work in each county. And of course, there's a good reason for that, but that leaves then a lot of flexibility and also a lot of potential places for gaps or missteps. And so some best practices are, when before the court order is documented, as Dr. Galusha said, really verifying that any of the service or requirements that are described either in the OMP or the actual final court order are available and able to be provided. I can't really stress that enough. It might seem sort of simple, but for example, if an outpatient provider has agreed to doing treatment, but they have not agreed to be doing electronic ankle monitoring, and that is written into a court order, that can really cause a lot of difficulties once the person's out, if that provider hadn't agreed to it, there's not funding for it, or the person's living situation has barriers. So really encouraging any and all thoughts of that court order to be thought of in advance, so that the right people can be aware and be taking steps before the person transitions to the community. And maintaining an accurate contact list for all these stakeholders. I think we're all familiar with turnover or know the outdated list they posted, and this can really cause a lot of problems. So maintaining that accurate contact list and making sure that is distributed to everybody who's involved in the NGRI outpatient commitment for the duration of that commitment, right? These can continue for a long period of time, and people move in and out of roles, and you want to make sure that is maintained. Designating those roles and responsibilities about how to renew the outpatient commitment, how to revoke it, modify, or terminate court jurisdiction. So you don't want to be coming up on a place where somebody is timing out and nobody's really familiar with what's going to happen for this person once that timeout occurs. We don't want to be leaving people without resources and support. We don't want to be leaving things up to chance because we haven't thought about roles and responsibilities in advance. And then proactively planning for how to address issues that can change, right? Service availability might change, compliance concerns, if somebody has a crisis or another legal factor comes up. Maybe somebody's placed in an HCBS AMH home, and that's a fantastic spot for them, and something maybe that provider no longer has it, or something comes with a city ordinance code and that home can't operate for a period of time, and so that person has to move, but maybe they move to a different catchment area from LMHA, right? These things can happen, and that's fine. And there's ways to modify court orders and make sure that treatment continues seamlessly, but this has to be sort of thought out in advance and make sure, again, that everybody is staying on the same page with communication. Next slide, please. All right. And then also be thinking about thresholds or triggering events that might go along with noncompliance or status change, right? So again, as we spoke to earlier, that two-prong is the reporting to the court with noncompliance and becoming a danger to self or others, or to others rather. But that doesn't mean that's the only time you want to be reporting on the court. Again, the intention of these outpatient plans is for the person's best success. So what does that look like? What does your local community need with the court, with the attorney, with the provider, and with the person to sort of identify, hey, for this person, maybe missing a couple of appointments, while not ideal, maybe it's because they are really stable and they're working and they, I don't know, stayed for overtime. Whereas for another person, missing the same number of appointments might be indicative of that person becoming non-compliant and risk of decompensation. So thinking about what those thresholds or triggering events might be and what requires notification within your local area. Those time frames as well. We don't want to say, yeah, you should let us know if XYZ, being clear about what the time frames are to complete notifications, which parties are identified to receive notifications and who is to be giving them. And then protocols to request or to modify a court-approved treatment regimen. These are all things that have general guidance in statute and also locally, but nailing those down, having them in writing, making sure that everybody is on the same page, especially across time and across the duration of a person's commitment, is very important. Next slide, please. All right, these are just some very broad programming options and resources just to bring some light on. I won't go super in depth, but of course, housing and general programming, a person's housing when they go onto an outpatient commitment can look as unique as their own needs and what's available to them, right? They might live with family members, they might live independently, they might live in supervised living. And similarly, the program options may vary based on treatment determinations and local resources. Next slide, which leads us then into some more specialized options on our next slide. Some specialized recovery management services and supervised living include things like home and community-based services to adult mental health, home and community-based services for people who have intellectual disabilities, the state hospital step-down program. These are all sort of middle ground step-down that might be determined the most appropriate for somebody. Whereas again, like I said in the previous slide, some people might go with family or in other situations. Next slide. Similarly, there's some specialized mental health service delivery models, such as assertive community treatment or ACT, or forensic assertive community treatment or FACT. These models work at an LOC4 or a level of care 4, which is the highest level of care through an LMHA or LBHA. This typically the type of level of care a person is going to receive as they go on to an outpatient treatment commitment is going to be identified in the outpatient management plan and then in the court order. But these are sort of specialized, and a person might stay on this level of care for the duration of their commitment, or over time they may step down. Next slide, please. All right, and then additionally, just some general types of programming, of course, outpatient substance use disorder treatment services, residential, and recovery support services. So again, this note across the bottom, you'll see this running theme that a court must confirm that these services or resources can and will be provided where the person is going if they are going to be identified in a court order. Next slide, please. All right, sort of lastly, additional considerations for NGRI outpatient requirements. The court or other relevant stakeholders may consider additional requirements outside of what's in statute. But again, there should be an establishment of how these are going to be implemented and monitored prior to the court ordering them. Some examples include things like how often the court check-in might be, electronic ankle monitoring, drug and alcohol testing, curfew requirements, restriction of movement, all these types of things. And I can't stress enough that if these are going to be included in a court order, if that's what's appropriate and best, that is great, but they need to be sort of discussed and established in advance. So again, a broader look at these pieces, we really defer to the court order and the providers in the local areas, but an overview of things to be thinking about as an outpatient commitment is being ordered. And I'll pass it back to Omar.
Thanks, Ashley. Next slide. So folks, we've thrown a lot of information at y'all today. And so as we get ready to finish the call, we just wanted to take a few moments to highlight some key takeaways we hope folks get from today's presentation. So first, after an NGRI finding, the court must receive information from the state hospital to help them determine the appropriate treatment setting for the acquitted person. So inpatient admission is appropriate when an individual has a serious mental illness or intellectual developmental disability and has been acquitted and had that determination of dangerous conduct. The state hospital is to provide a report to the court outlining their assessment of the person's needs. State hospital treatment is both clinical and public safety focused. The state hospital's role is not only to stabilize psychiatric symptoms, but also to assess and reduce future violent risk, build insight, support accountability, and document whether the person is ready for a less restrictive setting as required by law. Next slide, please. Discharge planning is a structured, collaborative process, not a single event. So successful community transition is dependent on an individual's treatment progress, clinical evaluations, and the violence risk assessment, as well as from input from various stakeholders, such as, but not limited to, the treatment team, the individual, court parties, the LMHA, LBHA, or LIDA, and community providers to create an outpatient management plan that will successfully support the individual. Violence risk assessment helps connect inpatient clinical progress to practical risk management. So a VRA identifies risk factors, protective factors, and management strategies so the team can recommend the least restrictive environment that still protects public safety. Next slide, please. Active coordinated stakeholder involvement is required across the full life cycle of an NGRI outpatient commitment. So this includes coordinated communication and planning for all aspects of the commitment. So for when the person is initially discharged from inpatient and re-entering the community, for modifications to their outpatient commitment, to the annual renewals, and to when the court ultimately prepares to terminate jurisdiction. All of this requires clear local processes and designated responsibilities that need to be established in advance. Court oversight is continuous and must be fully supported by verified resources. So the court must approve a detailed treatment and supervision plan for both the initial release and each subsequent outpatient commitment renewal. And before the order is issued, they must confirm that all required services are available and will be provided to the acquitted person. Next slide, please. Also, community success depends on clear roles, resources, and ongoing coordination. So once a person transitions to an outpatient commitment, designated providers are responsible for treatment and supervision, but they are dependent upon active court and stakeholder participation. Again, this whole process takes a village and multiple stakeholders to be involved throughout the continuum of care. Court requirements can vary significantly across communities and should be based on the established needs of the acquitted person and the confirmed availability of resources. And lastly, hospital readmission is not necessarily a system failure. Recovery from a serious mental illness is a long-term, sometimes lifelong journey. The reemergence of symptoms or relapse is entirely possible. Thus, having proper supports in place to promote treatment and engagement is critical. Someone needing to readmit to a facility is not inherently a failure, especially if the fact of doing so helps prevent a more serious outcome. And next slide, please. And with that, we just want to thank folks for taking the time to attend this call today. On the screen, you can see the contact information for our offices. So for our partners at Behavioral Health Services, you can reach them at HHSC, NGRI Outpatient Services at hhs.texas.gov. And You can reach us at the Office of Forensic Services and Coordination at forensics@hhs.texas.gov. And with that, we have a few minutes if folks had any questions, and I think I'll just hand it back to JCMH.
Thank
And I can
you.
help.
Yeah.
I'm happy to help. We've been trying to answer some of the questions in the chat here. I think we have answered quite a few. Let's see. So what, just looking at what we do have left. So this can be for anyone on the call right now of our panelists. If a person violates the terms of the OMP that were added by the court, like drug use, what action does the court take?
Ultimately, that's up to the court. So the court may choose to violate them and return them to the facility, or the court may choose to place additional modifications to their OMP and for example, may make them test more frequently or increase their supervision level. It's ultimately up to the judge.
I want to jump in there, Dr. Glusha. Thank you for saying that. We have heard reports. Illegal drugs are not a good example because that is illegal. But one thing that we have heard is that if there is a requirement in the OMP that is not necessarily illegal, that sometimes it is being confused as like a violation of probation and criminal charges are attempted. And that is a really important point of education, that the remedy is really supposed to be that civil recommitment modification route, and that this isn't viewed as a violation of a probation or something criminal.
I wanted to actually answer a question that unfortunately, for those who know me, I am not technologically savvy and somehow accidentally deleted the question. But there was a question from an anonymous member that was asking about how HHSC measures insight. And so essentially, the answer is that right now it is a clinical evaluation and assessment made by the recovery teams, as well as being evaluated in components of the violence risk assessment. Sorry, I deleted the question.
It may be in the answered questions, Dr. Wright. Is that the one about anosognosia?
It's not, but let's go ahead and, because that was the next one I was going to say I had promised that we would go back and address that from a clinical standpoint. So the risk assessment and treatment, I think Dr. Galusha, did you want to answer that one?
Sure. Yeah. Sorry, I had to go back and look at the question. So certainly we do take that into consideration in the VRA. It's one of the risk factors that we look at. And as Dr. Wright mentioned, it's part of the clinical assessment that's done by the recovery team. So it's something that we're looking at continuously throughout their stay. It's a common symptom of serious mental illness is a lack of insight. And so it's something we're obviously aware of and attempting to address through education and treatment. And then we are paying attention to, and we advise the court on and our team on when we're doing risk assessment. So it is all part of our formulation of risk as well.
Okay, and then I know, Sonia Burns, you've posed a lot of good questions about data, and I would say I believe some of this is addressed in Chief Jordan Dixon's presentation to the Senate Committee on Criminal Justice, and that is posted on HHSC's website as well, if you want to look at some of the data there.
Well, thank you. One of the comments is truly a phenomenal, informative presentation. So thank you all very
Thank you.
much. This will be recorded and you can register for if you watched it live for COE. And then there is a different form you fill out if you watch it after the live presentation to get your continued legal education. Thank you again to HHSC. And we will see you August 26th for the third installment on NGRI.